This is my POCUS grab bag, my credentials. So the objectives overall is just to sort of talk about a few different topics in POCUS. So this is definitely not going to be as focused as a talk on volume responsiveness in shock, for instance. It's going to be kind of broader, skimming the surface of a few things. We'll review a little bit of literature and then kind of understand the utility of POCUS in some of these indications that you might be able to use them, even in an ICU setting. And then also kind of recognize what the limitations are to POCUS so that we're not using it inappropriately. So we'll do this sort of as a case-based, 15-year-old girl admitted to the ICU in the setting of sepsis with epigastric abdominal pain and vomiting. So now on 2 pressors, she gets intubated to reduce metabolic demand. And this might be one of those scenarios where you have a patient who's just too unstable to go to CT, which, ideally would be the imaging of choice to see what's going on in her belly. And it seemed like she had some tenderness in the right upper quadrant or epigastrium, but obviously difficult to assess. All right, so just to start out, so what's the literature in using, right? Obviously, if you're worried about sepsis, right upper quadrant pain and tenderness, thinking about biliary pathology, there's a good bit of literature out there looking at the sensitivity of using ultrasound and, particularly POCUS for stones and other biliary pathology. And the sensitivity overall seemed somewhat low in this one study in 2018 for stones and sonographic Murphy sign, but the specificity is in the 90s. And another study, showed that there was actually change in management between POCUS and radiology ultrasound in terms of indications for surgery. And so thinking about this as many POCUS things, a lot of this is going to be sort of rule in versus rule out. And it's not going to be as good as radiology ultrasound just because of, probably a mix of technique and how good our machines are at looking at small structures. And so, again, you can see there's a wide range of sensitivity from good to bad, but overall the specificity when you do see pathology seems pretty good. And so, like a lot of POCUS, better rule in than rule out. The issue that we end up running into is anytime we want an ultrasound in radiology for the belly, if we're worried about, right could this be biliary? Could this be appendicitis? Could this be ovarian? We need a separate ultrasound order for every one of those studies that radiology wants to bill for. And so that can get into, 3 different studies. And sometimes doing some screening with POCUS where I can scan everything in the belly that I want, while the goal is to answer a question, I might still do a few specific scans that take me 5 minutes rather than having the patient spend an hour in radiology. And if I see pathology, obvious free fluid in the right lower quadrant, I might, concentrate there. If I see obvious biliary pathology, then I might forget about, sending them for an appendix scan and just concentrate on them going for a biliary scan. And so, in this case, you now want to look in the right upper quadrant. And so there are essentially 3 techniques you can use to do your biliary ultrasound. And with some practice, it becomes, for the most part, a fairly easy scan, at least to see most of what you want to see, with the difficult part usually being the common bile duct. And so I like to line my probe, up along the contour of the rib and sort of slide while looking up into the chest almost in order to look up under the liver. And you can see it sort of sliding along the contour of the liver. The next way you look is called the X-7 approach. And that's finding the Ziffy sternum going over to the patient's right 7 centimeters, and then being in a sagittal orientation. So now you're looking through the ribs, and almost always, as you look through the ribs right at that spot on the gallbladder. The downside to the next approach is that you can't test for a sonographic Murphy sign. And so the last approach is, if you're used to doing fast exams at all, it's basically doing your fast approach in the mid-axillary line of the right upper quadrant, looking through the ribs at the liver and kidney and into Morrison's pouch, and then fanning anterior. And so as you look to the anterior part of the abdomen, usually the gallbladder will come into view. And if you do fast exams, you'll see the gallbladder accidentally, tons of times when you're looking too far anterior. And so what do you see? Looking, right, you see liver, which we're all used to. The non-thick walled thing traveling through the liver is going to be the hepatic vein. And then this big anechoic structure here is your gallbladder. And if you want to confirm that it's gallbladder, sometimes, they can look odd and you're wondering if it's vessel or bowel. There shouldn't be air in it like bowel, and it shouldn't light up with color. And then at the bottom of the gallbladder here, which is dependent, you see these shadowing white sort of pearl-looking structures. And so this is what stones will look like in the gallbladder. And you can see that especially when you get, all of them in view, you see this dense shadow going down behind them. The other thing that you want to look for then as signs of not just cholelithiasis, but cholecystitis are going to be things like the wall thickness. And then the one other thing that you can see here is this little strip of fluid next to the gallbladder, just above it right here. And that's pericholecystic fluid. So that's free fluid that shouldn't be there. So you're going to want to fan through in two planes. You're going to look through the long axis of the gallbladder. And while we often talk about our two planes being, transverse and sagittal, in this case, you really want it to line up with the gallbladder itself. So don't think about it so much as transverse and sagittal, as much as you want to think of it as long axis and short axis of the gallbladder. You're going to look for stones and sludge. You're going to look for surrounding fluid like we just showed you. Ideally measuring the anterior wall thickness. You don't want to measure the posterior wall thickness because of posterior acoustic enhancement. It'll be falsely large because of the fluid inside the gallbladder. And so it should be the anterior. And then ideally you want to measure CBD size. So just some more examples of the gallbladder itself. Here you can see, a generously sized gallbladder, no pericholecystic fluid around it. And the gallbladder wall itself up here looks nice and thin. You can see down here how bright it is behind the gallbladder. That's that posterior acoustic enhancement. And so you can see it obscures the thinness of the wall. And then you can see these dense shadowing stones sitting in the gallbladder. Here's just another example of seeing a bunch of stones lined up next to each other with dense shadowing. And here you can see that anterior side of the gallbladder, the anterior wall. Even without measuring, you can see that it's markedly thickened. But clicking through, you don't see pericholecystic fluid, but there's definitely signs of gallbladder edema or inflammation along with stones. So that would be concerning for cholecystitis. Sort of more examples here, since all gallbladders look a little bit different. There's a whole bunch of stones with dense shadowing. And the most important place to see stones is at the neck of the gallbladder over here. One stone floating around over here in a patient with no other signs of infection is probably just asymptomatic or symptomatic cholelithiasis without cholecystitis. You have to be pretty worried about this many stones or stones that are sitting in the neck of the gallbladder. Here, as opposed to seeing those sort of dense, bright white circles, we're seeing more of a layering and looking kind of, debris with some shadowing. So debris will not always have shadowing, but might have some. And so this is gallbladder sludge. It's a little hard to tell the thickness of the gallbladder wall, but it's probably not overtly thick. And if you want to tell if this is really sludge, you can roll the patient. You can do the same thing with stones, and you can see if they move, right? The sludge should relayer in the dependent region, and stones should also move, as opposed to polyps. Luckily, polyps are not something we typically see in the pediatric world, so that distinction is not usually that difficult. Here are bigger stones. You can see, these gigantic stones sitting in the gallbladder with dense shadowing, and again, a thickened gallbladder wall. And so you want to measure that wall, and the upper limit of measurement is going to be 3 millimeters for gallbladder wall thickness. It's just highlighting those. And again, this is the picture that we saw earlier, just highlighting that pericholecystic fluid in that area. So sometimes you look and you're looking around and you're looking around and you can't find a gallbladder. Is anybody familiar with this image here? So I know that interactive on Zoom is difficult, but so this is something called wall echo shadow. So I want you to notice how dense this black is here. And Wes, so wall echo shadow is when the gallbladder is essentially so filled with stones, and I'll go back to the image, that you can't even see the gallbladder because the stones are reaching up to the anterior wall of the gallbladder, and you just can't see anything behind it. And so making sure that you don't mistake this for a piece of bowel with, dirty shadowing behind it, you can see how dense this shadow is. And so this is not a piece of intestine next to the liver with shadowing behind it, but it's in fact a gallbladder that's chock full of stones. And it's all densely shadowed behind. So next, you want to try and measure the CBD. So when you're looking for the CBD, you want to sort of see the gallbladder come down to the MLF here, and we look for what a lot of us call the Mickey Mouse sign, and it's essentially seeing the portal vein, which is going to be a thick-walled vein. You should see two other little ears, these two other structures, and when you put color flow on them, one of them should light up, which is the hepatic artery, and the other one should not, which is going to be your common bile duct. There's some data that if you have normal labs and you don't find other biliary pathology and you can't find the CBD, it's very unlikely that there's biliary pathology. But it is nice if you can find it, because sometimes you just have a CBD obstruction without seeing all the other signs of cholecystitis, and you may not see stones in the gallbladder anymore if the only one that there was is now in CBD. So this is one of the things, right? In ultrasound, we measure, internal to external, external, internal to internal on different things, whether it's, fetal head size, whether it's aortic diameter, looking at aortic aneurysms, or it's external to external. So CBD, you're going to measure internal to internal. And there are normals essentially by age. I will tell you there is some variance in what people consider normal, depending on the sources that you look at. But we have had, errors even in our shop where it's sort of deemed normal based on adult norms, whereas in a younger child, it should really be smaller. And we did have one case where biliary pathology was missed on radiology ultrasound, not a POCUS, because they sort of used the wrong norms to calculate what it should be. And so this is just sort of matching it to age to some extent. A minimum size for a CBD is sort of strange. I don't think we think that much of these minimum sizes. But really the maximum in millimeters we do think a lot about. And so it shouldn't be, 5 or 6 in a 3-year-old. That does go up with age. And then the adult CBD, we often think of as a mean of about 5. So 5 to 6 probably considered normal, and even in our older teenagers. And then we think about it going up after about 40 or 50, every decade going up by about 1 millimeter, peaking at around 7 millimeters to 8 millimeters. And then post-cholecystectomy, so this will be sort of across the spectrum, even in younger people. After cholecystectomy, the CBD is going to be larger. So you're not going to be able to find the gallbladder, obviously, but you can examine the CBD, and the norms are a bit different. Typically up to 1 centimeter can be more. So the pitfalls of trying to do biliary ultrasound, the biggest pitfall is just running into bowel gas. Additionally, if you have a patient, so this would probably be fairly relevant in your shop. If you just have a patient with anasarca, or even just with ascites for other reasons, you can have pericholecystic fluid, And that pericholecystic fluid itself can make the gallbladder wall appear thick. You can have generalized edema, and some of that edema might be in the gallbladder wall. And so having some caution in the setting of ascites, trying to say that something is cholecystitis based on pericholecystic fluid or a slightly thickened gallbladder wall. If you do have bowel gas, then doing things like steady pressure to try and push the gas away, as well as trying all three different approaches to looking at the gallbladder can help. Because sometimes if you look through the liver more, you won't be dealing with the bowel gas as much. And then recent PO intake can make your gallbladder contracted. Radiology used to require an 8-hour fast in order for them to do biliary ultrasounds. That's been sort of done away with over time. But just be aware that you can have a contracted appearing gallbladder where the wall looks thick and the gallbladder is very small, just because they have recent PO intake and not because of pathology. And then, here's just an interesting image that also might be, again, more relevant in your shop than mine, of just a very large gallbladder. And so thinking about if you measure the distance of a gallbladder and it's greater than 10 centimeters, or you're just seeing this gigantic gallbladder in a sick patient, is what we think of gallbladder hydrops. And so we say this, that we diagnose hydrops in massive distension. People say between 9 and 10 centimeters in length. And typically, if you're dealing with this, you want to think more about this being the result of a systemic process, almost like, acalculous cholecystitis. And the most common reason that we see gallbladder hydrops in the literature is Kawasaki. I would argue in the last few years, it was probably seen more frequently with MISC and these sort of Kawasaki-like pictures with MISC, but can also be present in the setting of systemic infection like sepsis, rather than typically gallbladder pathology. All right, so case 2, a 3-year-old comes to the ED unresponsive. They attempt Narcan, which doesn't have any effect. They get IV access and the patient's intubated. And admittedly, in our setting, once we intubate patients, we try to go to the ICU essentially as quickly as possible. Obviously, it would be nicer to have a little bit more information in a patient like this, but usually in an unresponsive patient who doesn't need more, quote unquote, resuscitation, they get intubated, they get a head CT, and then they go up to the ICU before all of the workup has been completed. And so this patient has a normal head CT and goes up to the ICU. And we're wondering why she's unresponsive. And so it's sort of interesting. I think one of the first papers actually publishing this was a pediatrician at St. Agnes in Baltimore, who it was one of the sort of resident teaching hospitals affiliated with Hopkins, but it was a private entity. And there was an old pediatrician there who I think was one of the first descriptors of this process of intussusception presenting as altered mental status. So we tend to think of this process as vomiting, this intermittent crampy pain of the child drawing their legs in to their chest. And usually, for sure there's going to be vomiting. But interestingly enough, intussusception can present with lethargy alone. And we're not entirely sure why. There's some thought that, at least my understanding is there's some thought that there are endogenous opioids that get released and you get this opioid-like picture. And so some kids have even been reported to respond to Narcan when intussusception is the cause. But obviously, we look for opiates as well. So the technique to look for intussusception is generally quite simple. This is talking about ileocolic intussusception. Right. I hope you guys like my artistic skills. I drew this child myself. Is really just that sort of horseshoe shape you can see here going along the colon itself. And here's a demonstration of braided compression, because obviously when looking at bowel, it's very likely that you're going to have air interference. And so being perpendicular to what you're looking at, you want to put slow, steady pressure in, and sometimes quite, vigorous pressure. And if you hold in place for a minute, the air will often, be pushed away and you'll start to see clarity in the image that you're looking at. And then you want to go up to the next spot, do the same thing, slow, steady compression, wait for the air to go away, and then you'll see what you're trying to look at. And again, just showing the technique. Now you would use graded compression while doing this is going to be this essential shape of going up the ascending colon across the transverse to the descending colon and looking all the way down to the sigmoid. So what are you expecting to see in this setting? So the classic description of intussusception is going to be seeing a target sign. And that target sign is the area where one piece of bowel, the intussusceptum, is, involuting into the intussuscipiens, which is the outer piece of bowel. And so if you see this, you want to note it, you want to measure it, and also it's good if you can take some color images. This is a long view of the same thing, the intussuscipiens on the outside, the intussusceptum on the inside, and you can see sort of the outer intestine here and here. And this is actually a bit of a nicer view of the inner piece of intestine telescoping into the outer piece. In oblique, it's going to be more of the pseudo kidney, which can be interesting because in small children, when you're looking in this area, you might actually see their actual kidney with a linear probe looking anteriorly. But you can see this, there's no, big vasculature or renal medulla. You're just seeing the bowel and the bowel. Now, on the other hand, if you see the same type of picture while you're sort of lawnmowering the bowel or even just doing this typical approach, and you measure it and it is only 2 centimeters across or less than 2 centimeters, then what you're dealing with is probably a small bowel intussusception, which is one of the big pitfalls of this exam. So bowel gas can get in the way. Again, you might see an actual kidney and be concerned that it's a pseudo kidney sign. If you see a small bowel intussusception, ideally just sort of rescanning that area about between 10 and 30 minutes later, and then looking for other signs of obstruction as well. Small bowel intussusception can be pathologic and typically requires surgery if it's pathologic, but typically it is transient. We also get a lot of transfers of kids who get CT'd at other hospitals for abdominal pain, and they'll see on a static image, they'll see a small bowel intussusception, which is why ultrasound is nice because it's dynamic imaging. And there's ongoing literature sort of looking into the sensitivity of POCUS for intussusception. And it's a very easy scan. And the literature so far is showing that POCUS is probably about equivalent to radiology performed ultrasound for intussusception. All right, case 3. You have a 12-year-old with prior abdominal surgery who is presenting with vomiting. She's hypotensive. She has a distended abdomen. Your x-ray is inconclusive, and you consult surgery, and they want you to get a CT scan with PO and IV contrast. And so you're going to be waiting about 4 hours for the PO contrast to go through her system before you can get the image. So you pull out your trusty probe, and you start with a fast exam. You see no free fluid in the fast spaces. And so you decide to lawnmower the whole bowel. So now you're just sort of shooting in the dark, trying to go through all your abdominal scans, looking to see if you can see obvious pathology that might help you radiology performed ultrasound or even convince surgery to do something. And so in this case, you're going to lawnmower the entire bowel rather than just, looking across the large bowel. And this is what you're looking for now. So if you see loops of bowel, you can see, sort of the outer part of bowel here and here. There's all this debris inside. You measure across, and you get about 2.5 centimeters. As you keep looking through, you see what kind of looks like a keyboard. Call this the keyboard sign. And these are the plicae circularis of the small intestine. And then we see to and fro peristalsis. So you can see that rather than things moving all the way through, they're stopping and going back the other way. So if you see these signs, does this prompt you to think of anything that we're getting at? I'm sure you're all thinking it. But here you can see another image of to and fro peristalsis and the keyboard sign in one image, as well as a nicely big dilated loop of bowel. Here's our last sign, in the setting of, what we're dealing with is a small bowel obstruction, and this is called the Tinga sign. Tinga is Portuguese for thong, and it's basically referring to these triangles of free fluid between circular dilated loops of bowel. So you can see this is free fluid here between the loops of bowel. And so there have been some attempts now to, develop some kind of nomogram to predict small bowel obstruction, to look at the accuracy of small bowel obstruction. The results of these are a little bit all over the place as far as how good it really is compared to CT being the gold standard. And ultimately, what's interesting here is it's instead of being a rule in versus a rule, the typical approach to POCUS being a rule in, most of the evidence actually shows that POCUS is more sensitive than it is specific, with the sensitivity being as high as the 90s to even 100% in some of the studies, with specificity more in the 80s. So you might see things like ileus present with the sign, some of the signs of SBO on point of care ultrasound, or gastroenteritis present with, dilated fluid-filled loops of bowel. And the cutoffs for how big a dilated loop of bowel is in a child are not very well described. And we still generally use 2 to 2.5 centimeters because that's what's described in adults. So now what if you're looking at the belly in the same patient and she's quite sick, again, distended bowel, distended belly, she's hypotensive and maybe hypertympanic. And you see perhaps some free fluid, but interestingly, rather than intraluminal, you're seeing right at the top of her belly, this dirty shadowing. And so this is actually what you can see in the setting of free air in the belly. And point of care ultrasound can actually be pretty good at looking for free air in the belly. And there's been described this gut point too. And I'll show you kind of where you look for that is more in the right upper quadrant. And so there's a point over the liver that you're going to look for this. But people talk about rather than a lung point, like you see in pneumothorax, where you have A lines coming in and out, where in lung ultrasound, the A lines are normal. In the gut, seeing these A lines not coming down from the bowel, but coming down from the very top of the peritoneum, that's abnormal. You shouldn't see, obviously, air. So this gut point is concerning for free air. And we can see it in this image where it sort of comes in and out, that free air coming directly from the peritoneum. And obviously you want to be careful that you're not thinking of, intraluminal air, but often you can tell that difference. And so this point 2 of looking in the right upper quadrant is that you're going to be over an area where you shouldn't have bowel interference. And it's really tiny, but you can see right at the top of your screen here, there's a little spot of air. Sometimes you'll see this sort of thing inside the liver in the setting of gas-producing abscesses, but this obviously is external to the liver and is in that area that you see above the right, under the right hemidiaphragm. When you're looking on X-ray, you can see this little bit of air coming up above the liver. All right, so moving on. Now you have a 7-year-old boy in the PICU for a hypovolemic shock in the setting of acute gastroenteritis. He's waiting for a bed on the floor after he's been stabilized, and he develops abdominal pain as well as tender right lower quadrant. Pull out your trusty linear probe. And now you're going to do that same sort of exam with graded compression, now focusing in the right lower quadrant. And you're going to focus where this box is, close to the pelvis and going up to just about the umbilicus, maybe a little bit above it. Again, lawnmowering that area and using graded compression. And the landmarks that you're looking for are these sort of major things here. So here you're going to see your psoas muscle, nice looking filet mignon. You're going to see two vessels. Well, there's three vessels, kind of like the spot they're looking into two. And so this is your artery. You can see it pulsating. Your iliac to femoral artery. Here's your iliac vein. And then you can see this little circular structure up here that has gut signature. You can see it has layers, typical for gut signature. And so again, psoas, iliac vessels. Here's actually the bigger artery just above here. And so right there, right around where the iliac vessels are, crossing the psoas is where you're going to look for your appendix. You want to see that gut signature that we're talking about. So again, it's going to have the layers of bowel. I'm going to be honest, I don't remember all the layers of the bowel. You want to see that it's a blind ending structure. And so you want to ideally follow it for its entire course. And then you want to measure across. And here, 0.44 centimeters, you can see this is quite a small sort of ovoid shaped appendix. And so as you compress, you can see this is squashing, sometimes fully disappears, and definitely changing shape as you let go. On the other hand, here is, if you fan a little more, you might see it sort of blind ending on one of these sides, but it's probably coming off the bowel here and blind ending on this side because it looks like there's a sort of dense shadow down here. Measuring across here, you can see this is much bigger. And to be honest, this measurement could probably actually come all the way out to here. And so this is, a large non-compressible appendix, 0.65 centimeters on this one. So you can see the appendix, but the other things you want to look for is you can also see around here, it's very hyperechoic surrounding tissue. It's sort of like what we see with cobblestoning in the setting of cellulitis, and it just means that there's edema in the soft tissue in this area. And so that's suggestive of inflammation. You can also put color on and try to look for hyperemia. It's a little harder to define. And so again, lots of studies now trying to look at point of care ultrasound, looking at appendicitis. And so suspected acute appendicitis. So ED POCUS, had a likelihood ratio of 9. So pretty good rule in. Likelihood ratio, a negative likelihood ratio of 0.17. So that's actually pretty decent. And if you incorporate it into your history and physical and your pre and post-test probability, it's actually not a bad scan. The only warning I'll have is it takes a while if you can't easily find the appendix. And so, one of the arguments is, should we be able to rule in appendicitis to the satisfaction of our surgeons with point of care ultrasound, but perhaps not rule it out? Here again, POCUS had a good overall, they looked at sensitivity, specificity. And so the sensitivity of 0.85, interestingly, the specificity was much lower here at 0.63. And you'd have to look and see what their criteria are, because if you only use size, you can have a normal 7-millimeter appendix. And sometimes people only look at size without looking at the other parts of the scan. But overall, you can see it does, increase and decrease your positive and negative likelihood ratios. And so it's still worth doing because it can change your suspicion, especially in a setting where you can't get a patient to CT or radiology ultrasound isn't available, for instance. So just sort of more studies looking at how good POCUS is for ultrasound. So this was a meta-analysis, and positive and negative predictive values of 91 and 94%. So if you add your clinical exam to that for your pre and post-test probability as well, that can influence obviously your positive and negative predictive values. but there was a lot of heterogeneity. And then here, they used more of this sort of staged algorithm, and still had decent, sensitivity and specificity. Not amazing. And the exams overall had pretty good agreement between POCUS and radiology performed ultrasound. So we have limitations to radiology performed ultrasound, obviously, as well. But it is the kind of thing that if you have a patient who really fits the story, you have labs that are suggestive, and you have a point of care ultrasound that looks like appendicitis. In some places, surgeons may be willing, if they can view those images and have them explained to them, they may be willing to take patients to the operating room. So again, just another meta-analysis, again showing you can just see sort of the range of sensitivities and specificities, but overall somewhere between 80s to 90s%. So overall, decent rule in, not as good to rule out. And again, it takes time. So what I like about a lot of our POCUS scans is that I can go in and try to get a quick answer for a question. If I have a patient that I have a high suspicion, especially if I'm teaching, I'll teach these scans. Our surgeons are not typically at the point where they're taking people to the OR based on our scans. And so if the patient tells me it hurts right here and I put my probe on right where they say it hurts and I see something, it's helpful. If I look in the classic places and sort of lawnmower the bowel a bit and I see something, it's helpful. If I don't see anything by that point, 5 minutes, 7 minutes in, I tend to give up because I don't have the time to spend 30 minutes looking for an appendix. That's a time, where I need radiology to do it. All right, we're doing okay on time. So 1-month-old baby in the ED for vomiting and weight loss. We had this patient. This is one of the great ones that I taught, a fellow. She did the scan, saw the finding, and as soon as I left, the baby stopped breathing because he had a pH of like 7-8 from alkalosis, from metabolic alkalosis. Went apneic, got intubated, and so this is a patient that could end up, theoretically coming up to the ICU before diagnosis. And on your gas, you have a hypokalemic metabolic alkalosis. So you put your linear probe on the right upper quadrant. Now you're looking in this right upper quadrant box again in a small child. And obviously we're looking for pyloric stenosis here. And so you're looking in this area. This is around the same place that you're going to see a duodenum. And in a normal setting, you're going to see a canal that has air. And here's the muscles on either side, not super thick. And here, again, just a more focused view of the channel and the pyloric muscle. And one easy way to remember your measurements is pi for pyloric stenosis, 3 millimeter muscle thickness and a 14 millimeter channel length. Our surgeons, for some reason, use 4 and 17, but that's not what I've seen classically described in the literature. And so here's one where you get this, target symbol of your pylorus. You see your channel in the middle. You measure across at 5 millimeters, so that's definitely thickened by any criteria. And then you look in long view, and you can see it's 17 millimeters across. Again, they could probably even stretch this out a little bit further in terms of the measurement. And you can see a thick muscle wall, thick here. You see the channel, and there's not even air, in the channel. And then this one last thing here is you can actually see that the pylorus is, the muscle is pushing into the antrum. Another example here, a really clear image, long length of 20 millimeters, 21 millimeters, 5 millimeters across. And then this we call the antral nipple sign. So again, this is, pretty diagnostic for pyloric stenosis. If you see the proximal end of the channel is actually being, pushed by the muscle up into the antrum of the stomach. And then you can see there's all this fluid in the stomach. So pitfalls here, stomach air, obviously there can be a lot of air in the stomach. There's often going to be a lot of fluid in the stomach because this baby, fluid hasn't been passing and the baby's been hungry and trying to feed over and over. And that fluid can be a nice window to be able to see through. Just keep in mind, an over distended stomach sometimes pushes the pyloric posteriorly and makes it difficult to see. And so then in your setting, right, say this child wasn't intubated, but now you feel like it's time to intubate this patient. What if they've recently eaten? So this is kind of the next area that I think will be interesting. I didn't find good, like, I think this is kind of the next like set of questions to think about in terms of belly ultrasound. And there's some data going back, but using abdominal ultrasound prior to intubation is becoming, one of the new kind of hot buttons for anesthesia. Can it help determine what their intubation plan should be? And basically, this is looking at the stomach to see how much debris is in the stomach. There's airway ultrasound as well, obviously, as a separate from this talk. But looking at the stomach itself and trying to see if there's a lot of stomach contents versus air, and trying to use that to determine your intubation plan. It's somewhat, I think, more relevant for anesthesia because all of my intubations in the emergency department are rapid sequence intubations, or modified RSI, and patients vomit all the time, unfortunately. It's not really the same controlled situation, but you might start to see some stuff coming out looking at measuring stomach contents prior to intubation. So that is my talk, and happy to have any questions or comments.